Hi, I'm Dr. Dana Haaf. I'm a family physician on the North Shore, and I'm here to talk today about aging and cognition, the topic being cognitive decline. Is it real or imaginary? So what is cognitive decline? This is something we deal with every day in the family practice office with aging population. We see this more and more. There's a lot of confusion around what is memory loss, defining cognition, trying to define dementia. Of course, there are varying risk factors depending on what causes any of these conditions. And so we're going to be talking today about differentiating normal aging versus cognitive decline versus dementia, and try to give you some definitions of what some of these are and risk factors and outcomes that we see. So what is cognitive decline? So concerns, the definition is fairly broad-based. There's not really a clear consensus, but typically we define cognition as sort of multifunctional, multifaceted brain function and how we interact with our environment and how that environment interacts with us. So cognitive decline would be any sort of diminishment of a person's abilities in those different areas. So concern of or difficulty with their thinking, memory, concentration, and a multitude of other brain functions that we use that people can come up with. It all would be defined as cognition. Working memory is another term we use quite a bit, and that's really kind of involving things that we do day to day that we don't usually even have to think about, but are important parts of our interactions in our day. Cognitive decline can come on suddenly, can be gradual, and there's different diagnoses that we see that that would determine whether this is something that's more gradual versus something that's more sudden. And also we see cognitive decline includes delirium, and delirium has its own separate definition, but it is something more transient, something more temporary, and usually something more reversible. Of course, this can all be very scary for the person experiencing this, as well as for their family and friends. We see differences between what young people experience with memory loss and forgetfulness versus somebody who's older, and the impact that this has on an older person can be a lot more unnerving than it is for somebody who's younger. So further to that, so we, as people, we develop many sort of thinking abilities, different aspects of our brain function. Typically, we feel that it peaks around the age of 30 with sort of the maximum amount of brain cells and synapses, and that, of course, these definitions are changing all the time, and we're now seeing that the definition of how many brain cells and synapses and functional interactions in our brain that we have doesn't necessarily stop at around 30. It can actually develop even further. Terms like neuroplasticity plays an important part in our brains as we age. So we're learning more and more about this very complex organ in our body as time goes on and science advances. However, typically our maximal sort of generally our functionality in our brain kind of peaks around our early to mid adulthood, and typically does start to decline. And we see that in these areas like overall slowness of thinking, multitasking, our ability to sustain concentrated thought over long periods of time does tend to diminish slowly at varying stages or varying degrees as we get older. So when does initial forgetfulness become cognitive decline? As I was alluding to earlier, like people, when we're young, we often can forget why we walked into a room, forget where we put our keys, forget little things, but we don't really think too much about those. But as we get older, they become more important, and sometimes they become more more often and more involved in different aspects of our life. So more often losing things, forgetting important events, forgetting appointments, forgetting conversations, trouble coming up with words, names, objects, things like that. And sometimes patients don't notice it. What I call patients, people generally, don't notice it as much as family and friends and other people in their lives. When that happens, we tend to get more concerned. So forgetfulness versus cognitive decline. Being forgetful just basically is what it sounds like, forgetting things, losing track of things. Sometimes it's just a matter of forgetting somebody's name that you don't see every day. Forgetting where you put your keys is a classic one. Just little things, forgetting why you walked into a room. And this is pretty normal. And as I said, when a young person does it, they write it off as something that's normal. When an old person does, they get pretty concerned. And I see a lot of people in my office coming in because of that, and they forget appointments, they forget conversations. As we'll get to soon, there's a lot of different reasons for that beyond just simply cognitive dysfunction or cognitive loss. So forgetting things more often, when it gets to be more than just forgetting some objects or forgetting somebody's name, when it becomes forgetting important things, forgetting things that are important to your family, forgetting things that are important to your health, forgetting doctor's appointments. I see that sometimes. And in certain patients, of course, it makes me more concerned when patients who normally are always there and on time are suddenly forgetting and getting their weeks mixed up, getting their days mixed up, thinking that they're coming in to see me on a Friday when I've never worked on a Friday in my office, and things that I know that they know, but they are becoming and more forgetful of, and sometimes not even aware that they're forgetting. They're mixing up facts and not even aware that it's a mistake. Feeling overwhelmed with making decisions, multitasking, multi-thinking, having to keep track of multiple different aspects of complications in a day-to-day life. We see this a lot with driving, because although we think driving is a simple task, it actually involves a lot of complicated thinking that we take for granted. Rote thinking is a common thing that we see. So this is things that we've been doing for years and actually become forgetful of how to do those. Becoming more impulsive and kind of doing things without thinking through them beforehand. So this is something that I see a lot when people are becoming more forgetful, when their cognition is starting to decline. They are aware of this, as opposed to dementia, where people often don't have insight, don't realize that they're having this problem. And because there's a lot of different reasons for cognitive decline as opposed to dementia is just one cause. A lot of people with cognitive decline are aware that they have cognitive decline, and there might be some other reason for it that's actually either fixable or something we can manage and treat and identify for them, or help them to identify those. And oftentimes I find that the people who come in to me and say that they're becoming forgetful, that they're worried that they have dementia, is usually a golden rule that they don't. The people who are brought in by their family and have concerns about cognitive decline and the patients denying it are the ones I worry about. So confusing cognitive decline with anxiety and depression. So mental health, more than just anxiety and depression, but these are probably the two we see the most in family practice. Anxiety and depression involve brain function and the ability to sustain thought, attention, concentration, different terms for the same thing. So people can't concentrate, you can't think, you can't focus on something. It is difficult for that information to get into the brain. So if you think of your brain as a bank of information, if it's not even getting into the bank, you can't make a withdrawal. So it's difficult for you to be able to pull information out that never got in there in the first place. And people think that they're forgetting, but the information never was attended to in the first place, so it didn't get in. So as opposed to actual real forgetfulness is where they knew the information was there, the people around them knew that they heard it, knew that they understood it, and yet later couldn't remember it. But even that with mental health, sometimes there's blocks in the brain with depression and anxiety where people have the information, but they can't recall it. They just can't get the information out. And we've all had that where we are trying to remember a name, we focus on it. The more you focus on it, the harder it is. And then you walk away from the conversation and aha, that name comes to you. And so that can be from a variety of things. That's not necessarily a problem. And I mean, the last point, there's grief, there's depression, there's adjustment disorders. There's a whole bunch of things that are in our Diagnostic and Statistics Manual, called the DSM, that some people have heard of different diagnoses in mental health. They can all have some degree of impact on this. And trying to figure out which diagnosis a person has may actually be helpful in managing that problem. And also give them some reassurance. So causes of cognitive decline, this is just a few of them. There's lots of different problems. Vitamin deficiency is one that a lot of people get interested in because health and wellness is very important, especially as we get older. How much a person eats and what they eat and how much they're getting of different vitamins becomes important. Should I take a multivitamin? What vitamin should I take? Essentially, the ones that we see the most are calcium and vitamin B12 are the two most important that we can test for and identify and help with a person's overall mental health by through various investigations. Depression we talked about, medication, there's a bunch of medications ranging from medications we even use for mental health, medications we use for treating a lot of common problems that can cause confusion and can cause a person to become more, to lose attention, to lose focus, become sleepy. You can include in there painkillers, medications that help for sleep, a number of different medications for various different problems. And all, of course, those should be discussed with the doctor and reviewed and interactions discussed as well. Hormones, changes in hormones through a person's life that we see, whether it's decreases in testosterone, decreases in estrogen, progesterone. Thyroid is a hormone, and that's a common one we see that causes problems. People don't think of these necessarily as hormones, but insulin, so diabetics. Chronic disease also causes a lot of issues. And we can see here the kidney, the liver, so certain diseases that increase toxins in the brain that can interfere with brain function as well. Most of this is testable and we can identify a lot of it. Alcohol, drugs, so certain substances, of course, even prescription drugs I mentioned before. Strokes, head injuries, and of course Alzheimer's, Parkinson's disease. These are causing different types of dementias. So we refer to those as neurodegenerative diseases or conditions. Delirium. This is a whole other topic, but basically even things like infections, whether a person has pneumonia, urinary tract infections, which become more common in elderly people. We see those a lot as causing confusion, but that is often reversible or improvable with treatment, antibiotics or other medications we can use. So risk factors, we talked about diabetes. This is by no means indicating that what's at the top is the biggest risk factors. All of these to different degrees can cause problems, and they lead to other conditions such as strokes and TIAs or mini strokes, and diminishing brain function. High cholesterol, high blood pressure, diabetes, smoking, all four of those are significant risk factors for causing heart disease and strokes. TIAs and mini strokes is a really important one because a lot of people can go for a day or two and have some stroke-like symptoms and then just attribute it to something else when they improve back to normal. And the definition of that is we can't identify it on scans and tests. And so risk factors that are potentially going to lead to strokes and TIAs are very important to know. And for patients to tell their families and talk about their symptoms they're having at those times so that they can come to our attention and discuss it before the memory fades on that and they forget they had it. When we talk about sudden changes in a person's cognition, strokes are a major cause of sudden cognitive change. So when should you see your family physician? As the first point indicates, regularly. So regular is different for different people depending on what your health is like. So if you have a chronic illness like diabetes, we usually see patients anywhere from 4 times a year to twice a year, checking their blood work, checking up on their medications, talking about their diet, checking their weight, these kinds of things, to see that they're trying to follow the recommendations to try to help enhance their health. To see us before there's a decline. I mean, typically we'd love to be able to take everybody age 65 and over and do cognitive assessments on them and start that process. It's very difficult, and of course nowadays we're seeing the bulge of baby boomers and now Gen Xers starting to get towards that age where it's becoming more and more higher numbers of these people and overwhelming the healthcare system and us. Like, we just don't have the time to do these, but it's up to the patient as well to come in and ask for this, to be aware of decline in mental health and cognition, and to get baselines and then check every 2 to 5 years depending on risk factors, but to talk about these things. So all these things, whether it's weight management, cholesterol, diet, diabetes, high blood pressure, smoking, less of a problem than we used to see, but certainly is around. But alcohol is a big one. Substance, probably the most commonly overused, misused substance that I see, and is hidden. People are much more willing to tell me that they smoke marijuana than that they drink alcohol and how much they drink. And usually I'll do a 2-to-1 rule on anything anybody tells me, and that I double whatever they tell me and what they say they drink. And it's usually turns out to be true. So, and then the point of the last 2 points is really important because it's well known and has been pushed upon society in the last few years that there are no doctors out there, and they're starting to see some improvements in that. And the North Shore has one of the highest physician to patient ratios, and there is some available spots that physicians have now on the North Shore, and we can help through divisions to get people connected to a new family doctor. I get requests every day for people to come and join the practice, and it's most of my colleagues are in the same boat. It is tough. It's getting a bit better, but it's still tough. So how to prevent cognitive decline? We're still working on the science of this, but we do know that neuroplasticity is a real thing, and so people can improve what they have. They can maximize their potential. You can do things like Sudoku and puzzles and crossword puzzles and chess and things that are mentally stimulating. Exercise is really important because blood flow to the brain is really critical to help deliver healthy nutrients and to take away toxins that can cloud the brain function. And you can improve and enhance blood flow to the brain with exercise. And mental exercise is exercise for the brain, and MRI studies show that increased blood flow to parts of the brain that are being used in certain exercises. So we know that you can enhance both neuroplasticity and vascular flow to the brain by physical and mental exercise. Of course, exercise also helps with mood and mental health as well. So this is a good slide that really just kind of shows, when I talk about dementia, that's dementia and cognitive decline are two different things. Dementia is a multitude of different causes. As you can see, Alzheimer's, that most people have heard of, is the most common. Vascular dementia, frontal temporal lobe dementia, Lewy body, which is often part of Parkinson's disease, and other dementias, including alcohol misuse. That also, alcohol can cause a form of dementia. And then, of course, there's a mixed type, so what we call mixed dementia. Most commonly we see as Alzheimer's and vascular dementia, but it can be a mixture of any of these. Just sort of depends on what a person's diseases in their body and their background. Usually they can get some indication of that. And usually those people, when they're a bit complicated and have multiple health issues, we refer them to a geriatric specialist who can help to differentiate those things. So again, dementia versus Alzheimer's. So a lot of people confuse these terms. Dementia is more the umbrella, as we saw in the last slide, all those different types, and Alzheimer's is a subtype of dementia. So there's Alzheimer's dementia as opposed to Alzheimer's and dementia. They are the same thing. Alzheimer's is a form of dementia, so it is the same as dementia, but not all dementias are Alzheimer's. So just a brief talk about advanced care planning. This is really important, and this is when you want to do this when you have your cognitive faculties in place. So if you are starting to notice cognitive decline, it's not just something that's occasional, it's becoming more problematic. It's important to have discussions with family, identify family members who are going to be good candidates for helping you if you need it down the road. Having a will, having a power of attorney for legal and financial matters, and having somebody for medical representative or a substitute decision maker. So my voice is put out by the government. It is a free method for people to be able to get these legal documents in place. If they don't have much money, you can certainly go to a lawyer and have a lot of these done up as well. I think the most important thing that I find with my patients and families is being able to educate them on the difference between a power of attorney and a medical representative, and they are not the same thing. Power of attorney is for legal and financial, and medical representative is a person that helps make medical decisions only for the patient. And it's important to have both of those. So that's basically what this slide kind of tells you here is essentially differentiating between those. And in the United States, they have different terms than they do in Canada, so it's important to talk to your doctor or your lawyer. Any of us can help you differentiate them. My voice is a way for you with your doctor that you can do these forms. And of course, a family lawyer would be able to, or a state lawyer would be able to have all these documents as well and in more depth and be able to customize those for individuals as well. So as part of that is to make sure once you do get these the paperwork in place, that your family doctor has this information. If you end up in the emergency room somewhere, the likelihood is that if you have one contact number for medical support as your doctor, we can then help those other doctors and healthcare providers to identify what your wishes are. You might be in an accident, you might have had a stroke, there might be some reason why you can't communicate, you might be unconscious and difficult to reach others, but the doctor can help identify. And the most likely scenario is it's going to be in your own community. And so it may be at Lionsgate Hospital, and they'll be able to identify me as the family doctor, contact me, and I should have this information. So it's just a repository for information on important legal documents for people. So make sure that when they're done, get copies to your doctor. So cognitive assessments, this is, so when people do have a perceived cognitive decline, and they want to get their cognition assessed, this is one of the tools that we use. This is developed in Montreal, so it's called the Montreal Cognitive Assessment, or MoCA for short, so we can have a bit of Canadian pride on this one. And it's quite widely used. There's different versions of them, so you can't study it in advance. I have had people do that, and we can just pull out one that they didn't use. But it's basically looking at various different aspects of brain function. So often people come in and they think, I have memory loss. I need a test for that. This is not just a memory test. There's actually just one part of it that is for pure memory. The rest of it is different aspects of cognition. So when we're trying to identify people, if they have issues in certain parts of their brain that help with visual spatial function, naming, rote memory, some other aspects of these with abstraction are usually, these are about more sort of in-depth, complex memory functions. So they're part of memory, but they involve different parts of the brain. So if you had a stroke that involved a certain part of the brain, your memory could be intact, but you may lose other functions that we can pick up on these testing. So it's a broad way of looking at cognition. So we call these cognitive assessments. Patients often refer to them as memory tests. So as I said, the MoCA was one of them. The mini mental status exam is another, or MMSE. That's a common one that we use as well. And there's other tests as well. We can also, if we're really not sure and a person is struggling with aspects in their life that involve cognition, we do have assistance with that. There's other testing that occupational therapists can do through North Shore Home Support Services that they can access if we would need them to, or refer to a geriatrician who can also help with that. So these are just some of the areas that we see in different brain function. Language, orientation, attention, focus, executive functions. That's more around like higher level decision making. Like if I go to the store, what am I going to do there? If I'm going to drive to somewhere, how do I get there? And thinking through the higher level processing, visual spatial abilities, and of course the short-term memory. So this is something I see quite a lot, particularly the audiology component. As we age, we often lose hearing, lose eyesight, and these are both ways, critical ways, that we get information into our brain. And it's very common that if you lose a bit of your ability to multitask, you lose your ability to pay attention for longer periods, and you're having a conversation that's lasting a while and you also can't hear it, you're going to pick up little bits. You're not going to be able to retain. There's a lot of things going on in that situation. So hearing assessments are often overlooked. It's embarrassing. People don't want to talk about it. They feel that it is an admission of age. There's lots of reasons, none of which are ones that we would want people to have prolonged in their life. So to get their hearing assessed, your hearing can be assessed for free in the community. There's a lot of skepticism about audiologists, the feeling that they're just going to try to sell you hearing aids. But people are willing to go buy a car from a car dealer. They're willing to buy glasses from an optometrist. But for some reason, they feel audiologists are not to be trusted. But they are professionals. They do get the information to us. We make the decisions with the patients, not the audiologist, and it is really a good idea for most people. There's not really a set age, but I'd say probably anybody who's noticing that they're having some trouble hearing, particularly in loud spaces or places where there's lots of different noises, or if their spouse is commenting on it, there's no reason not to get it, or at least to come and see us. Sometimes it's as simple, I've seen this many times, just syringing out earwax. That's all it takes, and it can make a big difference in a person's life. But when there's a real hearing loss, it can definitely make a difference. Visual assessments, most people are pretty good at staying on top of that, but of course, if you're not, picking up visual stimuli, you could lose out on things that could affect memory. Plus, you're having to focus so much more on that, you may not be paying attention in other ways. So again, coming back to the point of why I'm here is, as a family doctor, we're sort of the first point of contact in the healthcare system. It's confidential, it's private, it's personal, and it's somebody you can trust to talk about all of these things, whether it's mental health or diabetes or blood pressure or hearing loss, or if it's true cognitive decline, all of those reasons. And to see your doctor and have a relationship that you can develop trust before these things happen, because these are difficult conversations for individuals to have. And I think it's very important that you've established a relationship with that person who may be able to help you and certainly can help you through the journey, and hopefully can help you with the problem if it is something correctable. And even if it's not, I mean, one of the most valuable things I do is dealing with people and their families to help through situations to make something that's terrifying a little less scary as they go through that part of their life's journey. And that's it.
I was thinking there are questionnaires on the internet for all sorts of things, hearing tests on the internet, alcohol consumption. Are there any tests, home tests, do-it-yourself tests for cognitive decline? Anything that would say, if you score this, you better go see your doctor?
Nothing reliable. I mean, there's no science that sort of put out a home-based test. I think if a person, my rule would be, if you think you need to do that, it's probably a good idea to see your doctor. That would probably be a pretty good way to approach it. But there isn't really any like short questionnaires, other than if one tried to do the MOCA or MMSE. You can pull those off the internet and do them yourself. But it's difficult to know. Like, if you score a 25 out of 30, what does that mean? You could find out, but a lot of that information is misleading and could be wrong. Trying to get interpretations of things, that's where people run into trouble. Doing the tests is easy to find, but it's how do you interpret it? And do you get a false reassurance out of it and then don't see your doctor because of it? So I think a good rule generally would be, if you think you need to do the test, you probably should be seeing your doctor about and talk about it. And there's oftentimes people will come in for their physicals, or they'll come in for their blood pressure check. I can't tell in a 10 to 15 minute visit, which is what our limits usually are, to get into anything like that, because I don't talk about what they had for breakfast. I don't talk about other conversations. But there are times where patients will come in and I'll say, well, I know we talked about this a month ago, or they're in for the same thing and they don't realize I gave them the prescription last time, and I start to wonder, is there something going on? Like, why do you not remember that we talked about this exact same thing, or did that task just a short while ago? But those are kind of more obvious ones. It's the ones that are harder to pick up. People who come across pretty with it in the moment to moment, and they could be making stuff up. I'd have no idea. I wouldn't know. That's why objective assessments are so important, because they're in the here and now. And if you've got 5 minutes of time from when I asked you to remember these 5 objects and you can't remember them with no other interferences, then that could be part of a problem. Yeah, good question though.
I have a question. What would you like to see with regard to the family and the patient and that interaction? So what is your optimal partnership? Should they come in with the patient, or do you see them separately, or how? Because often it's challenging for the patient on their own because of denial.
Yeah. If I'm noticing the problem, there's different ways to answer that. Sometimes family members will bring it up to me. It's especially important, and we see this less and less now as family medicine is fractured in families. The husband will see this doctor, the wife sees this person, the kids are seeing the wife's doctor. We don't often even know who what the family unit looks like. And it's amazing when I have multiple members in the same family and I'll learn stuff about them. And Ruth can attest to that. When you raise these kids in the practice and they become adults, and then they're coming in and saying, I'm worried about my dad. And you've had this 30-year relationship with them. They can trust you. I've had this just recently with a patient who was starting to develop memory loss, and his daughter that I knew from my personal life from years ago gave me a call and said, hey, I'm worried about my dad. Like, he's really becoming more forgetful. How can we deal with this? And then after a couple of visits, her or her mom are coming in with all of the office visits now. And it's important to get phone numbers and contact information because we often need to relay information to those people. But because we're so restricted in time and availability, it's hard for me to be redundant. So it's best to have them come in with visits or be on the phone with them so that they can participate live in that interaction. So I don't have to repeat myself to fill them in, because I might have to give investigations and requisitions, go get a chest x-ray. Maybe they're just coming in for a simple chest cold and I want them to get a chest x-ray and blood work, and they're not going to remember to do any of that. Or here's a prescription for some antibiotics, and they go home and, well, what did the doctor say? Oh, not much. And they'll make it up because they're not in the state of mind to even acknowledge that they're forgetting, so they make something up. Well, the doctor didn't say anything. Well, if they know me, they'll know I did say something, and then either they have to contact me and then I have to recreate the work, or the patient doesn't get the investigations, and then next thing you know, they're in the hospital with pneumonia because they didn't get the chest x-ray, they didn't get the antibiotics, they didn't get the treatment, or they had a stroke because they never took their antihypertensive medications, or they're not taking their diabetes medications right. So sometimes the families aren't aware, and the patient is hiding their cognitive loss from their family too. So from my perspective, I want contact information. I want a go-to person who's reliable, who's accessible. And as I always tell them, there's often 2 or 3 interested parties in the family who all want to know stuff. And I'll just tell them, just pick one, please. And I'll have that contact person, and then they can relay out to the rest of you. If you're not feeling that information is getting passed along, then have more of you come in. But there's only so much room, and I don't have time for interactive questions. So it's just be there as a passive listener so you get the information. And that, generally, most people are pretty respectful of that, and they understand. But it's hard. A lot of people now, they're living across the world. They're not here with their family members. So those ones are the hardest ones, when they don't have a lot of local family. And then there's family living abroad, maybe in Europe or Australia, and then they're feeling guilty that they're not here. And that brings a whole other dimension of how they're interacting with us, when they sometimes can get quite demanding, but it's coming from a place of guilt because they're not here, yet we're being blamed for things that we are or are not doing because they're not really getting the information that they should be getting. So it can be difficult. There's a lot of emotions involved in cognitive decline and dementia.
Collateral information is helpful, basically.
Yeah.
Yeah. But the other thing to remember is for the doctor to talk to the family, you need, prior to dementia, you need the patient's permission.
Mm-hmm.
So it's good to get permission prior to full-blown dementia.
Mm-hmm.
Yeah.
With dementia, you need that power of attorney and representation agreement, that sort of stuff needs to be done.
Yeah, if we don't see the person until they have dementia and they don't have consent to share information, it becomes a very challenging legal situation, and that sometimes families can get very upset with us because we aren't legally obliged or able to share information with about a demented patient. Even if you think, well, it makes total sense to do it. I've worked a lot in nursing homes, and there's countless little posters and notices up from the nurses, do not talk to this person. This family member is not to be allowed into the unit or into the facility. There's a lot of emotional and financial manipulation. There's some pretty intense family situations, and particularly if there's money in that person's bank account, you get all kinds of secondary gain in family and friends, and you can't trust any of them. Even sometimes the ones that appear to be closest to the person of interest, they can be abusive in ways that they don't even mean to be. Maybe they don't have much money and they're struggling themselves, and they overtake from their parents' bank account. I've seen bank accounts be emptied from kids that don't appear to be bad kids, but they're financially abusing, and that money's never coming back. And they can't even be prosecuted for it because they had access. So it's difficult. I just kind of go by the mantra of don't trust anybody. If the patient trusts them, and as Ruth said, it's critical to get that access to share information before they go too far down that road. And then once we have that information on file with a trusted person, I mean, if there's abuse that occurs, we can't help that. We're not detectives. We don't know everything, but you just do the best you can to make sure the right people are involved.
I had one other question
Sure.
for that, and that is, so often I hear people say, oh, they're losing their memory, their parent, or they're calling. The next phrase is, but I don't want them to go in a home. What support, that's a huge leap, it seems, from the person is losing their memory to they'll need to go in a home. So without getting into how we got there, what are the types of supports? I guess as you start to peel back the diagnosis, then what is the goal here, ultimately, without automatically, well, they have to go in a home. So how does that unfold?
Well, I guess
it's a bit of a leap, isn't it?
Yeah. I mean, it's a hard one to answer because there's a lot of different steps in between point A and point X. Yeah. And the other one is to take away their driver's license. Going into a home and taking away their driver's license are probably the two biggest points of independence that people bring up all the time. I mean, usually we would want to collect as much information as we can about family structure, who's around, who can help, what their finances look like at a general level, what can they afford, if their goal is to stay home. I was with a elderly couple yesterday, we're in with their son, and halfway through the conversation, the son says, they want to stay in their home as long as possible. It's a common thing that people will say, and that's of course what most people would want, and it seems pretty obvious. But to focus in on that depends on a lot of things. Depends on what their health issues are. Like in this case, the woman, the wife, was having cognitive decline, and the husband has severe vascular disease and potentially looking at an amputation of part of his leg. So he's physically disabled. So between the two of them, there's a lot of challenges in the household. So one needs physical assistance, and we're having to get caregivers to come in and help him with showering and cleaning and care for his leg and dressing and some of those more basic mobility issues. Whereas the wife needs assistance with prompting and reminders, and we're concerned, of course, that the husband with physical impairment will get burned out and isn't capable of leading her around and helping with reminders and looking after those things. If you can imagine what it's like to have a grown-up 2-year-old who you have to remind all the time and prompt them, and even meals. Commonly they get day-night reversal. They don't know that it's dinner time. They don't check the time. They don't understand time as much. They don't know that they either just ate, so they overeat, or they forget that there's a meal coming up and they lose hunger cues. So then they lose weight because they're not eating enough. And it could be quite challenging. And if they have any awareness, they could be depressed as well. So we see people with like just reduced moods and interactions, and they just fade away. So you got to try to stimulate them. Well, that's difficult for an aging spouse if they're both in their mid to late 80s. So we see that a lot. And unfortunately, the one who is the most healthy dies first because they get burned out and sick. And a fall happens, they break their hip, end up in the hospital, pneumonia, die. And then the other ones emergently rushed into a nursing home because there's no other options for them. You got to sell your home. Their home might be on multiple stairs and levels. So there's all kinds of things.
A lot of stuff that's not just medical. This
Yeah.
is your social prescription stuff.
Yeah.
But the social side of dementia should, yeah.
You got 3 kids. The lawyer son is working in the UK, and the nurse daughter's in Australia, and the drug addict son is living down the street. Well, you can't trust that one. And the others are very difficult to reach. Time zone differences, office hours, like that's not an exaggerated situation. So it's quite difficult, especially in Vancouver, because it's so expensive for young people to live. A lot of older patients, their kids don't live on the North Shore. They're out in the Fraser Valley. They've moved to other provinces, and they're not as readily accessible. And then you got to get a hold of them when you need to, even if they are around. And quick decisions sometimes that need to be made. So it can be definitely challenging.
Great. Okay. Wonderful.